This week we get to talk about the fascinating organ of the placenta. I love this piece of art on the left. Amy Hatterer is the artist, and she was at our annual meeting this last year for ACNM. And so I actually have a few of her prints that are supposed to go up in my office soon. So when you guys are on campus, you should come hunt my office down and see what else she's done. But she's really worth hunting down. I just love her birth art. Okay, so let's start going on the placenta, one of my very favorite organs. Probably my favorite organ. Okay, so overview of the placenta. We're going to talk about implantation pretty in depth since this is the physiology course. And then let's get into twins because all of the really rote memory around understanding twins can come down to what does their placenta look like, and looking at chorions versus amnions for the membranes. Placental growth, and then we'll talk about function, amniotic fluid in the umbilical cord. Oops, that should not say placental function again, so we can ignore that. And then variations in pathology, and finally cultural beliefs around the placenta. So implantation, basically we have 3 steps. So we've already had our sperm that swam its way through the corona radiata barrier and then had that cortical reaction with the zona pellucida to get inside. DNA was exchanged, and then it's floating its way on down into the uterus. And then before it attaches, that zona pellucida is going to fall away. And I think of that as hatching. So the egg is going to hatch out of the zona pellucida in order to stick to our uterus. And that's twofold, the sticking. So we have the egg itself that's wanting to be sticky and get there, and then we have the uterus that's ready and waiting and wanting for it to attach. So the uterus ready and waiting for that adherence, we have, oops, that should say penopodes. I'm just going to fix that for us right here. So there's endometrial penopodes that are kind of like little foot-like projections that will help to grab it. And then the uterus has a lot of receptiveness to it. So there's increased vascularity, so it's ready and it's like edematous in a really good way. And then there's increased secretory activity. Endometrial penopodes are ready to interact with the trophoblast microvilli. So I guess the other piece I'll just mention there as far as the increased secretory activity and the vascularity is there's already lots of nutrients ready and waiting for that fetus to be able to pick up on right away. Okay, and then we have our trophoblast, which is the section that's going to turn into our placenta. So the trophoblast is getting ready to secrete proteases, so enzymes that are going to degrade the protein that's in the endometrium so that it can bury its way inside and get to the maternal blood vessels. So that's the erosion of the uterine epithelium piece. That's the trophoblast that's releasing those proteases. And something to keep in mind, we had an incredible feat for that sperm to be able to find the egg. And in your bonus folder this week, I put kind of a fun video that is the journey of the sperm to get there. So we know that it was a very long journey to be able to get to the egg in the first place. And then once it gets there, very few fertilized eggs actually end up getting to implant. So, well, up to half of them. So up to half of those eggs will implant, but then of those, only about half of them end up surviving that second week. So just because the sperm was able to find the egg, we're not out of the woods yet. And a lot of that has to do with how this burrowing goes, as well as just initially being able to set up that placenta. I mean, there's a lot of components that would fit into that, but that's what's going to be addressed, at least for this PowerPoint. And your last week's worth of content kind of plays into the rest of that, being are there chromosomal abnormalities that just aren't set up well enough for this to be able to take off? And then there's a good chunk that we just don't know why. But let's look at the placenta aspect anyway. So we see that we've, oops, I think I skipped a slide. Sorry there. Okay, so here's our egg The penopods and the trophoblast microvilli are just starting to make contact here. And so we have our trophoblast that's now going to be differentiated into two pieces that we're going to talk about. One is the cytotrophoblast and the other is the syncytiotrophoblast. The cytotrophoblast is going to be this layer all the way here, all the way around on the outside, and that actually has a cellular component to it. And then the syncytiotrophoblast is this piece that's starting to invade. So I'll go to the next slide and we'll get into that a little more. I apologize that this is full of numbers. I searched so long and hard, and these were my best images, so I used them even though they weren't labeled for you. So here we can see this darker green is our cytotrophoblast, so that's our inner cellular layer, and then our syncytiotrophoblast is this whole lighter green area that's invading. So then just taking a peek at what we have here as far as the placenta goes. So these two trophoblast components are what's going to end up being placental tissue, and then these are maternal capillaries. And so we're getting close to the maternal capillaries, and what the syncytiotrophoblast does is it starts to make these pockets here, and we call these lacunae. And so each individual lacuna ends up, like it means lake, lacuna means lake, so each individual one of these pockets ends up being a place where once it reaches the maternal blood can fill up those lacunae full of blood, and then that's how the placenta is able to extract the nutrients and the oxygen out of mom's bloodstream to send it over to baby. So we fill up those lacunas. So just to kind of give you a sense of a timeline, on around day 8, that's when we start to invade capillaries. So we're getting close to these here, and then on day 9, that's when the lacunae start to fill with blood, and we also form this little plug here. It's kind of like a fibrin plug, because we can have some bleeding when we're first invading here with the enzymes. And sometimes women will mistake that for having another period, so that can throw off our dating. So that's worth asking. When was the first day of your last period? And then was that a normal period for you? So if it's due to bleeding from implantation, it's more likely to be a much lighter period. And then it's also likely to have come a bit early. So if they ovulated on day 14, but then they're not starting to implant for another week, then it's more like, being somewhere in the realm of a week, maybe a little less than earlier than they were expecting to have their period. So that's a good question to ask. And then, so then it's not until day 11 to day 12 that the maternal blood is really coming into contact with fetal cells. And that's an important concept to understand, because up until that point, mom doesn't really know baby's there, because baby hasn't told mom yet, and baby doesn't really have any good contact with anything that's mom's. So that means a few things. So again, this is day 11 to 12 or so since fertilization. If baby hasn't had any contact with mom, then mom's not going to have a positive pregnancy test yet. So it's baby cells that are giving off HCG, and HCG, once that's in mom's bloodstream, that's what's telling her, hey, you have a pregnancy. And then that's what's making sure that our corpus luteum in our ovary doesn't end up finishing degrading, because we need it to continue to release all those hormones for us, because we certainly don't have a placenta developed yet, right? So it's not until around 10 weeks that our placenta is able to take over. So up until that time, the baby is going to be releasing HCG to remind mom's ovaries to keep releasing those hormones. And then the other flip side of that would be every once in a while you'll have a mom who comes in really anxious because before she knew she was pregnant, she went out drinking, or she was taking medications that would have been really bad for baby that we would be able to stop. So however that might play out, I think it can bring moms a lot of comfort to realize that typically speaking, if you don't know you're pregnant yet, your body doesn't know you're pregnant yet either, and baby doesn't have contact with whatever it is that you're doing that could be harmful for the baby. So how you end up phrasing that in a clinic situation, I would love to hear all your wisdom on that. But in general, if babies have a big insult early on, either it's not going to affect them at all because they don't have good contact with the maternal bloodstream yet in the first place, or it's such a big insult that the pregnancy is just really not able to take off. So in terms of thinking about like fetal defects or whatnot, it would be unlikely for it to have an effect like minor defects like that. It would be kind of an all or nothing situation. So that's day 11 to 12 that we start to have contact with mom, and then days 13 to 14 are when our primary chorionic villi start to develop and really get vascularized. So this syncytial trophoblast is going to get further and further in, and more villi are going to help to anchor it in there. So this is a similar image, but just perhaps one step further along. So you can see that all these lacunae have filled with blood. And we've got our good fibrin plug here, so we're all the way in. And keep in mind that this is still mom's tissue all through here. Great. So next up, we're just going to take a peek at what's happening when we start to come into contact with mom's capillaries. So before, when we were learning about uterine anatomy, we talked about straight arteries versus spiral arteries in the endometrium and how that played into menstruation. Well, now the trophoblast starts to come in contact with these spiral arteries, and it replaces the smooth muscle. You can see the smooth muscle in here. This is a before. It replaces this smooth muscle and the endothelium here with trophoblastic cells, which you can see here. And that's going to help us have a much larger diameter so we can get a high blood flow with low resistance to our placenta, because that's what we're needing for baby. So to not have to worry about any kind of constriction, just we want a lot of blood flow. So that's that high conductance piece, and low pressure so it can just flow right in and be secure for baby that way. So, I mean, once you have a placenta that's good and well established, that's 500 milliliters a minute. That's crazy. So we want high volume, low pressure. That's what we're looking for. Which is something to keep in mind if you're having trouble with the placental delivery at the birth. If you have a placenta that's half come off but not able to all the way come off, then you have all this blood that's still constantly going to that placenta, so that can be a hemorrhage situation. But at least for pregnancy, we're glad that we have a nice, good amount of flow. So if something goes wrong in this process of remodeling our spiral arteries to be like this, if that doesn't happen, then you have more incidences of intrauterine growth retardation. So if we can't have that high volume, then baby's not able to grow at the same rate. And then the other incidence we see is preeclampsia. So one of the theories on the etiology for why preeclampsia happens has to do with inappropriate remodeling of spiral arteries. We think of it as something that doesn't develop until way late in pregnancy, and yet all the way back to this initial implantation and development of our placenta, we're having factors that can contribute to the development of preeclampsia. Great. I think that's all I was going to say on that. Okay, so we just took a big leap. I'm actually going to go back so we can see where we were. So here we are, and then as our baby starts to grow, it's going to push these maternal maternal cell layer out and bulge. So when we come to this slide here, you can see that we used to be just a little egg that had burrowed in right here, and then as it got bigger and bigger, it presses into the lumen of the uterus. So as far as maternal cells go, we still have all of this right here. All of this is going to be lined with maternal cells, and then it continues here, and then this inner part here is all lined with maternal cells as well. And we have a different way we call each of these. And this part here would still be maternal cell on the other side of all this trophoblastic activity. So this part we call the decidua basalis, B-A-S-A-L-I-S. B-A-S-A-L-I-S. B-A-S-A-L-I-S, yes. And then this part here we call the decidua capsularis. And important to note, I mean, actually, I don't know that it's that important to note, but over time, this is going to get thinner and thinner, and then it eventually basically just disappears. But this is the decidua capsularis, and then this part here that doesn't have any contact with baby is the decidua paritalis. So that's how we can divide the three. So decidua basalis is where the trophoblast activity is taking place. That's ultimately our placenta. And so when we shed the placenta after the birth, we shed all the way down to the myometrium layer. So the decidua basalis is shearing off along with all these fetal components. So what we're looking at for the maternal side after a birth is the decidua basalis. And the last thing to note for this side is that at this point in the gestation, you can see that these villi are all the way around. And we refer to this as villus chorion because it looks so villous. But what you'll see in the next slide is that while this stays as villus chorion all the way to the end of pregnancy, this whole area surrounding the embryo, is going to become smooth chorion. So it will change from being villus chorion to smooth chorion. So when you think about the membranes after the birth, we have this outer layer that's our smooth chorion, and then we have our inner layer that would be our amnion. So amnion is closest to the fetus, and then coming out from that is the chorion. This picture doesn't blow up very well as far as words, so I'm sorry about that. But this was just my attempt to show you. In this picture, you can't really see it, but you can definitely tell that it's, well, I don't know if you can definitely tell, but it's villus chorion here. And then you can see by the time you get to here, it's very clearly smooth chorion, and then this part is villus chorion. And all the terminology that I was mentioning, the decidua basalis, the decidua capsularis, decidua paritalis, that's all written here. And again, I apologize that it just didn't blow up well. And I promise I looked for better pictures for a very long time. So, best I could do there, sorry. Okay, so this is after our first trimester, once our placenta has developed quite a bit more. So this is where all that trophoblastic activity is taking place with the decidua basalis. So here we see these are all of our maternal arteries and veins coming through the decidua basalis. And then right after this here, this would be our myometrium that's not featured. And then we're coming towards the lumen of the uterus. So as we inch in here, we can see just really nice free-flowing blood in these pockets here. And so we refer to each of these sections as being a villus. So we can see that the fetal villi are dipping down into the maternal blood zone, if you will. And that's going to help to anchor the placenta to have them be dipped like that. And then it'll also help pull all these microvilli down. And it's important to realize that mom and baby's blood are not mixing at this point. So we can see that this is mom's maternal artery and vein, and then over here though we have baby's vein and two arteries. And it's from the perspective of the baby. So this umbilical vein is heading towards baby's heart, and that's what's carrying oxygenated blood. Whereas baby's arteries, these two little arteries, are going away from baby's heart, and they have the deoxygenated blood heading back towards mom to get reoxygenated. And we'll get into that when we talk more about cardiac development, but just easy to see it pictured here. So there is no mixing in this process. We just have this nice open pool where blood can flow, and then all of the good nutrients are going to get absorbed into our bloodstream here without the two types of blood ever mixing. But you can see here that in these, so these are referred to as septum, placental septums, but you can see here that if we were to say have some micro tears or bleeding, it could start to fill up in these spaces, and that could cause the placenta to start to shear away from the wall. So just something to be aware of, and that would be an abruption, whether that was little or big. It's not uncommon to see part of the chorion slightly pull away from the edge of the maternal side early in pregnancy, and I'd say that's the #1 most common reason I see bleeding in clinic. It's called a subchorionic hemorrhage, and usually it just ends up clotting and resolving itself, but it's just kind of the edge of the chorion there that's pulling away and causing bleeding. And that would be bleeding from mom, not bleeding from baby. And their blood wouldn't be mixing because it would be on the outside of the chorion, so that's in that extra area of the uterus that's really not touching the baby at all. But just something to be aware of in understanding how that's fitting or working out from a developmental standpoint. Okay, so let's keep going. So that's all I have as far as getting into the nitty-gritty of the physiology. But let's just look at some really awesome pictures. So I just think this one is beautiful. And you can see all our chorionic villi here that would be heading into the endometrium. And then here's our placental vessels here. We'll keep going here. You can see that early in pregnancy, the ratio of the placenta to the baby is pretty big. So the placenta starts growing off at a much faster rate than the baby does. And then baby will eventually catch up. And then by the end, placenta is only a pound or 2, and then you've got a baby that's 7-8 pounds. So placenta starts out being the weightiest piece anyway. I do limited ultrasound, so I wanted to include some pictures here. Know that that's not part of your baseline scope as a midwife, but it's absolutely something that you could add to your scope as a midwife. So I have quite a few friends that are nurse midwives and do limited ultrasounds, which would mean doing like early ultrasound scans for dating or for viability. So like checking in if you had a mom who was bleeding, or if you were needing to verify dates. And then you could do biophysical profiles and checking in on amniotic fluid at the end of term, or making sure that baby's head down. Those are definitely pieces that you could be trained in to do in addition to your scope. And then some of that might come down to hospital policy for what your actual practice allows you to do, but know that as far as your scope is concerned, that's definitely something you could add. So this is an early scan, I would guess maybe 8 weeks. And I just wanted to point out here, so our uterus is like this piece all here, and then I don't know how far out it goes from there. So that's our uterus, and then here's our gestational sac, this whole big black area. And then it's not until around 12 weeks that our chorion ends up fusing with our amnion. So right now our chorion is all the way on the outside of this whole image, whereas our amnion, you can see a little silhouette of it here, which I think is kind of fun. So as baby grows and as amnion grows, eventually the amnion will end up kind of fusing, well, not fusing, but rubbing up against the chorion, and then they're just wet enough that they'll kind of stick, if you will. So there's that. And then until our placenta is well developed, baby ends up getting most of his or her nutrients through this little yolk sac here, which you can see is this little ring. And eventually that'll just kind of get absorbed into the umbilical cord. But you can see that in the early scans. So if you were doing an early ultrasound, you'd probably measure up and down and sideways, so transverse and anterior posterior for the gestational sac, and that can issue a due date. And then a much better due date would be the crown rump length. So I would probably rearrange this till I had a better side profile of baby, but I would put a marker right about here, and then I'd put a marker right about here, and then they would be able to calculate a due date for me for the crown rump length there. And that's going to be your most accurate form of dating, is once you have a little crown rump length. Great. So we'll keep going. I have one more here. I have a little gummy bear. And you can really see the amnion well here. There's our amnion that'll end up fusing with our chorion. And you can also measure the yolk sac too. Oftentimes women who miscarry, their yolk sac is extra large prior to the miscarriage. Okay, so we can see here that once baby gets much bigger, that's about the ratio of placenta to baby. And then if you're looking at the placenta from the maternal surface on this side, this is what you're going to see. So all these cotyledons, each of these little chunks we'd call a cotyledon, and then there's all these sulci here. So making sure that all the pieces are accounted for after the birth is important. And then on this side you can see this is what baby would see from the inside. So all these blood vessels that are baby's blood vessels, and then here's our cord. They're amnion and chorion, so that's a nice smooth shiny side. So looking at real pictures then, this is the fetal surface, which you'll hear people talk about this looking like it's a tree of life with all these blood vessels. And then if the placenta was delivered and this is the first side you saw, you'd call that a Schultz presentation for your placental delivery, as opposed to if it was the maternal surface, you would call that a Duncan presentation. Usually you would see it as a Schultz presentation. So you can see that this side looks a lot rougher. And so it's the shearing away with the basalis, and then oftentimes there is a little bit of scarring wherever that placenta site was later. So when we think about the next time someone becomes pregnant, if there's any scarring in her uterus, whether she's had surgery before or whether it's a site from an old placenta, the biggest one though being surgery, like a past C-section, when that next baby goes to implant, that scar tissue is kind of easy for the egg to kind of catch on to, if that makes sense. That rough edge ends up being something that can more easily pull an egg towards it. And so when that ovum goes to implant, or it's not really an ovum anymore, when that blastocyst goes to implant, since this area with scarring doesn't have as thick of a basalis layer, it tends to burrow deeper than the basalis layer, and that's when you have a placenta growing into like the myometrium of the uterus, making it really hard for that placenta to be birthed after that baby is born. So something that strikes fear in the heart of midwives is you have a baby and then your placenta is not coming because it's growing into the uterine muscle. All the more reason to be lowering our C-section rate in this country. And then also just being aware that the more babies a woman has, there is just a little bit of scarring each time there's been a placenta there. Great. And then just to think about when you first look at this, oftentimes you'll see a lot of blood here and maybe big clots and chunks of blood that you kind of need to pull away. And that's because, generally speaking, for third stage, when the placenta is about to be birthed, some blood, so the baby comes out and then the uterus rapidly becomes much smaller than it was, which makes this placenta start to shear away a little bit because it's kind of buckling and tearing from all the limited space that it has, and then that's going to cause bleeding. And then those clots start to form behind the placenta, which makes it separate more and more and more. So seeing lots of clots and blood on the other side of your placenta is common, and just make sure you're wiping it away well before you take a good look at it to make sure that you haven't left any chunks behind. So where does the placenta implant? It can implant anywhere as far as I'm concerned, as long as it's actually inside the uterus and it's not covering over her cervix. So if a placenta is covering over her cervix, we can't have a baby out her vagina, because you can see that if the cervix was starting to open, we'll go over this one, then the placenta is right there. The placenta is just going to start to bleed. So can't birth that way. So generally speaking, though, our placenta is going to implant in the back, so the posterior surface of her uterus, but usually it ends up being anterior by the birth, oddly enough. But really anywhere is fine. Up on the fundus, in the front, in the back, more to one side. Being aware of where it is good for the birth, but it doesn't really matter as long as it's not covering over her cervix. And then something to keep in mind, say we have this one we're calling a marginal placenta previa, previa meaning that it's covering over her cervix. It's starting to get in the way there. As the uterus grows, this tissue here is also growing up and out. And so oftentimes, whatever you have on like your 20-week anatomy scan, wherever the placenta is then, it will tend to look like it has moved upwards and away from the cervix with time. So if on somebody's 20-week scan we see that it's maybe slightly covering her cervix, it's worth checking in again because chances are it's going to move out of the way and not end up being an issue. So our cutoff for a vaginal birth, something to remember, is 2 centimeters. So it needs to be at least 2 centimeters away. And then we know we're good to go for a vaginal birth. So that cutoff is 2 centimeters. Great. Another random piece of information is if it is more to one side than the other, it's usually closer to the side that the woman ovulated from as far as implantation placement. Okay, going back to ultrasounds here, I just thought this would be kind of fun to show. So your transducer is here and it's in her vagina. So this has come through her vagina and then this is what we're seeing on the other end of her vagina. So this here is her cervix. You can see that just really thin black line. This is her cervix. And then we can see here that this is her placenta, this echogenic area or lighter colored area. And so her internal os is right around here. So this is kind of the way her cervix is going. And our placental edge is really coming pretty darn close. And then the way this particular ultrasound measured it ended up being less than 2 centimeters over it, and likely that one's going to end up moving. So I think maybe they had the edge defined as coming to here. So less than 2 centimeters worth of covering that internal os. So if that was a 20-week scan, then more than likely we'll be able to get out of the way by the time we get to the birth. So just doing repeat ultrasounds to make sure it's moved. But if it starts out really close, but isn't covering it, I mean, the likelihood that it's not going to get out of the way is pretty slim. Okay, so let's talk about twins. So basically 2 types of twins, right? We have fraternal twins and identical twins. So if we have fraternal twins, that means that the mom ovulated twice. So maybe she's more likely to do that, or maybe she was taking a medication like Clomid that encourages your ovaries to be more likely to ovulate more than one Graafian follicle. But whatever the reason, it was 2 ovums that came out, so they are going to be genetically like siblings. And if that's the case, you have 2 eggs that are floating into your uterus and 2 eggs that are implanting. They each have their own chorion, which means if you have your own chorion, you'll automatically have your own amnion too. That's the inner bubble, right? That's closer to the baby. And then as far as the placenta goes, you have 2 placentas. Though on ultrasound, sometimes it can be tricky. Those 2 placentas could look a little bit like they're fused as 1 placenta. But it would be 2 placentas, but they might look fused. Okay, so that's the dizygotic twins. Monozygotic twins, meaning we started out as 1 ovum, but depending on at what point we turned into being 2 babies, that's going to determine what our placentas do. So if they end up separating pretty quickly, then you'll end up with the same situation as the dizygotic twins. You'll have 2 chorion, and then they could look like they're fused as 1 placenta, but it's really more like 2 placentas. Or if they take a while to end up separating, then you would just have 1 chorion. And again, based on when the 2 separate, you could have 1 amnion as well, or you could have 2 amnions. So it'd be like 2 little balloons blown up inside 1 balloon. I think balloons is a nice way to think of it, versus them being like a balloon inside a balloon that has 2 babies in it. Okay, I'm going to show you pictures, so I apologize if I just made that confusing. Okay, we'll look at this one more way, and then we'll look at some better pictures. So, this is, well, here down, this option A could be dizygotic twins from here. But let's think about this as monozygotic twins. There's 3 options. Either they separate really early on, and then we see here they're separate, they're implanting separately. This is our chorion with our little amnion inside. And then what we have here is two separate placentas, each with their own chorion and their own amnion. That's what a dizygotic would look like as well. If they take a little bit longer to separate, then you might end up having one chorion, but two amnions within that bubble, which you can see here. So here we have one chorion with two balloons inside, as opposed to chorion with its balloon, chorion with its balloon. And then this last option, if we take a really long time before we separate, which sometimes this will also come with conjoined twins and other complications as well, we see that we have one chorion and one amnion, so both babies can have interaction directly with each other inside here, and that's a lot more rare. So just to go into that again, dizygotic twins, we have two placentas, two chorions, two amnions, and this is really obvious to me in this ultrasound because this is a chorion with its own gestational sac, this is one with its own gestational sac, and then you can see, so that's two chorions, and then we have our two amnions inside as well. And this is clearly like a fixed septum that's got some tissue to it. Like there's no way this is just amnion, right? So then our next option is option 1 for monozygotic twinning. And that would be two chorions, two amnions. So that's going to look the same as the last slide. We had an early split, and then you can see both our little embryos are embedded on each side there. So one zygote is splitting into two morulas, so two full blastocysts, and then the rest would just look the same as that dizygotic twinning. We have two eggs implanting. So option 2 for monozygotic twins would be one chorion and two amnion. This is what the majority of twins are going to be. So we have two embryoblasts containing one blastomere, and then they share the part that's going to become the chorion, and they're implanting together. But you can see here that they're each in their own amnion. So they might share a chorion, but they have their own bubble inside. And you can see this is the placenta up here that they're sharing. So then looking at this image here, you can see this thin amnion is definitely separating them. So that's not a thick piece of tissue, but then that's definitely something that's present. I have only had the privilege of diagnosing twins twice, and since I was doing out-of-hospital birth, it meant I had to transfer them, but I tell you, it was really fun finding it for the first time. So, weren't expecting it at all. Okay, next picture. Monozygotic twinning. Oops, this should say option 3. Sorry, guys. Okay. One chorion, one amnion. Again, this is rare. And they are sharing one amnion and one chorion, so they're both inside it together. And I don't know if this ultrasound really is that. You just can't see the chorions or the amnions, so it might very well be that this isn't really one chorion and one amnion, but that was as close as an image as I could find. And then these two babies, to me, sure look like they don't have an amnion separating them. So really, ideally, our babies are separated. When they're in the same sac like that, there's a high rate of entanglement. And so this would be related to just a really late separation, and we're likely to have conjoined twins, or to have what we might refer to as like a parasite issue, where one baby is able to funnel a lot more of the nutrients than the other one, based on how closely they're sharing the placenta. So you have one baby that's growing at a really great rate, and then another baby that's really suffering from IUGR, or intrauterine growth restriction. Okay, so moving along, I've already alluded to this, but just showing that in terms of the length of the pregnancy, the placental weight picks up a lot faster than the fetal weight. So here's our placental weight, and here's our fetal weight. And it's around 32 weeks that your placenta caps out at growth. So it's not like it's an ongoing growth piece that whole time throughout pregnancy. So placental function, I am not going to go into a whole lot of depth here since I've already gone through a lot of depth with implantation and whatnot, but Placental function metabolism, so contributes to fetal nutrient supply, rate of oxygen and glucose consumption. So it's functioning as far as regulating the rates there. It's functioning similar to the brain. It's a transport mechanism, obviously, for oxygen between mom and baby as well as glucose, right? And then endocrine, huge. So many hormones. I would love to get into all the hormones. I don't have time to get into all the hormones. But just for knowing your top 4 dogs, HCG, or human chorionic gonadotropin. That's released by our syncytial trophoblast once we're implanting. And then we have our HPL, which is our human placental lactogen. And then progesterone and estrogen, which we already know. And then immunologically, the placenta is helping with protection so that the mom isn't rejecting the baby. So it's a nice in-between there as far as mom not necessarily recognizing baby from an immunological standpoint. And then also we have those IgG antibodies that are crossing over the placenta to give baby protection as well. So IgG is the placenta, and then at birth, once we're breastfeeding, that's IgA antibodies that are crossing over. So pregnancy, it's IgG. I think we have like a half a week on that later, so that will be to be continued. Okay, so looking at our hormones, HCG, that's what's maintaining our corpus luteum. We already knew that. So that's really kicking in those first 10 weeks. HPL is a huge player in promoting fetal growth. And then progesterone is our pro-pregnancy hormone, so decreasing myometrial activity, so we're not cramping and having a baby, right? So we keep everything in limbo during pregnancy. Limbo is not a good word for it. Everything quiet, so it's known as uterine quiescence in pregnancy. Progesterone makes everything quiet. It's constricting myometrial vessels, and then it's relaxing smooth muscles, which includes our GI tract. As well as our uterus, but that's why a lot of pregnant women are constipated, because everything is all slowed down. And then it increases our basal temp, along with a lot of other things, which we'll get into when we talk about physiology of pregnancy. Then estrogen is enhancing myometrial activity, promoting myometrial vasodilation, so that's great for our placenta. Softens fibers in the cervical collagen tissue, which will be good once we get ready for labor especially, but sometimes you can even notice that just in doing your pelvic exam as just one of those signs that's coming with doing an exam on a pregnant woman versus an exam on a woman during her annual. So there's more blood flow to her cervix, so her cervix can kind of have a bluish hue, and then her lower uterine segment especially kind of gets softer, but that is coming up in pregnancy, so we won't get into that very much right now. Yeah, this is about the placenta, not about everything the placenta is causing. So that would be a whole nother week's worth of content. Well, a whole nother week's worth of me doing this PowerPoint constantly. Okay, and then it's increasing prolactin secretion so that our breasts are getting ready for breastfeeding, along with a million other things. So placenta is responsible for causing all of those changes because the placenta is what's producing and releasing these hormones into the maternal system. That's the summary there. So transfer of substances. So we have simple or passive diffusion primarily. So this isn't active transport. This is all happening easily and passively. So high concentration to low concentration, that's what's most important here. So lipid solubility plays a big role in that. So cholesterol is a main component in the membranes, and pregnant women tend to have higher cholesterol, and this is partially why, is because it's related to being able to transfer substances easily across the placenta. Sometimes there's a little bit of capillary breakage, that can cause things to transfer that we didn't mean to transfer, such as thinking about like why we would give a pregnant woman Rogam if she's Rh negative, right? Because in the event that there was a little bit of mixing, we wouldn't want her to come into contact with baby's blood and make antibodies. That is coming up again, but just an example. Molecular weight plays a component to what's transferred, degree of ionization, and then protein binding. So those are the big players for determining what's easily able to diffuse. Uteral placental blood flow, we have 500 mils a minute. Factors affecting rate include changes in systemic circulation. So if a woman has lost a lot of blood, then that's going to mean that not as much blood is getting to the placenta, right? Or say there's changes in the number and size of uteral placental blood flow, that would affect it. Compression of uteral placental blood vessels, and then degenerative changes. So for all of these, I think about, well, I already touched on third stage bleeding. After that placenta has come out, we really want to rub mom's uterus and make sure that we can close off that open wound where this 500 mils a minute was flowing out, right? Because we don't want to continue to have her losing 500 mils a minute once the placenta is not there. So making sure her uterus is nice and clamped down. So if a mom has hypertension, that's going to affect these pieces, right? So that can really affect baby's growth based on how much blood flow is easily able to get to the placenta. And then contractions, like if a woman is having tetanic contractions in labor, where it's one on top of the other on top of the other, there's not time for her uterus to relax and get good blood flow back to it if it's constantly constricted. And because the blood flow in the uterus is running through the myometrium. So if it's contracting, then blood is not easily getting there. So wanting to have like a sufficient break in between contractions in order to improve blood flow to the placenta and thus to baby. Anesthesia can lower your blood pressure, which can lead to less blood getting to the uterus. Nicotine can have an impact too. And then thinking about degenerative changes with the placenta, so we know that it's continuing to proliferate and grow until about 32 weeks, and then it decreases in surface area that's used for gas exchange. And so we want to think about, how far are we past our due date, because our placenta is not made to carry a toddler. It's a time-limited organ. So that's the main thing we want to think about for people going past their due date is this placenta still functioning up to par such that it can be caring for this baby well. And there's two pieces of information that are most helpful for us to be able to assess that. One is we know that the placenta plays a role in influencing how much amniotic fluid there is. So if we measure how much amniotic fluid there is, we can see that it does slowly go down near the end of term, but if it's gone significantly down, then we want to have that in the back of our minds of, I'm not sure that this placenta is going to stay with us much longer, so we need to get towards delivery sooner. That would be something to think about. Although maternal hydration can play a big role in that too, so anytime you're going to be checking in on a woman's amniotic fluid, make sure she's really well hydrated, because we wouldn't want to misjudge that. And then the other piece too would be just how well is this baby doing? A baby that's getting plenty of oxygen, a baby that's getting plenty of nutrients, their heart rate's going to look great. So checking in on fetal heart tones by doing like a non-stress test, which all of that will be coming in more detail, both in this class as well as in many more classes. Okay, sources of amniotic fluid. Let's talk about amniotic fluid. So amniotic membrane cells, they produce amniotic fluid. So I'm talking about the amnion. So your amnion, the cells that make up your amnion, release fluid. Fetal urine releases fluid. That starts at about 9 to 11 weeks. The respiratory tract, just how when we walk around and sneeze and cough and just talk, we have little bits of fluid coming out of our mouths. Baby, the same thing, so that contributes to their fluid. Not nearly as much as urine would. And then we have maternal blood to placenta/membranes. That's going to impact it, as well as just interstitial fluid from mom crossing over the amniochorionic membrane. So that impacts it as well. And then fetal skin gets in there. And then I know I already mentioned fetal urine, but for the second half of pregnancy, the fetal kidneys play a much larger role, and that can be 800 to 1,200 mils a day that they're producing. So From there, then you would see like babies would be swallowing that fluid, which would kind of counter everything that we're making. And so it's just going to continue to be recycled that way and come to a basic sense of normal. So looking at our amniotic fluid volume throughout pregnancy, so we have our 40-week gestation here, and you can see how much fluid is accumulating throughout this, which I guess this is probably supposed, yeah, this is our 50th percentile. I was thinking we were hitting something really high there. So volume is going to vary based on gestational age, so just to be aware of that. So 98% of what's there is water. If moms do have a lot of fluid, half the time we don't know why, so we call that polyhydramnios. But it's multiple factors. It could be related to baby, it could be related, or I'm sorry, not just baby, multiples. So having more than one baby would lead to poly, and then having like a blood-related disorder, the mom having a blood-related disorder could impact it, chromosomal abnormalities, such as say they're not able to swallow, say those tubes aren't all connected there, then that fluid wouldn't have anywhere to go and would just keep building up. Neural tube defects can impact it, and then for oligohydramnios, or having particularly low fluid, that could be amnion abnormalities in early gestation, especially if the amnion is not able to be producing the bulk of that fluid early on, and then placental insufficiency, like we were talking about at the end of pregnancy, urinary abnormalities, so if something's not right with baby's renal tract, that's a big part of where our fluid's coming from. So again, thinking about chromosomal abnormalities, premature rupture of membranes, obviously if your water broke, you're not going to have very much fluid in there anymore. So all of those can impact why we're getting low scores on our measuring amniotic fluid. So in pregnancy, there's basically two different ways on ultrasound that you can measure fluid. One would be to measure the largest vertical pocket. So when we're doing BPPs or biophysical profiles, that's the component that's used, is you find your biggest pocket in each of the 4 quadrants, and then you just measure it top to bottom there. You can see a little bit of the cord here, which we'll look at pictures of that in a sec. And then the other way to do it would be the amniotic fluid index, or AFI. So to measure an AFI, you wander around in each of the 4 quadrants, and in each of the 4 quadrants you pick your biggest pocket, and then you measure that biggest pocket. So then you take those 4 measurements from each quadrant, and you add them all up, and then that's your AFI. So long as I've got your attention, I may as well share it all. Okay, umbilical cord. I have to show you this picture because it made me laugh, and I'm sorry it doesn't have a whole lot of teaching helpfulness, but I just thought that was hilarious. It's a phone charger looking like an umbilical cord. I'm very much a nerd, but I don't think I could do that. Okay, so umbilical cord, it's well established already by 8 to 9 weeks gestation. Contains 2 arteries and a vein, like we talked about before, and then it's full of Wharton's jelly. So that jelly is going to help prevent cord compression. So that way our vessels aren't getting pinched off. Vessels tend to be twisted as the vessels are usually longer than the cord. So I found you a picture that looks particularly coily. Our insertion is generally central into our placenta, so it inserts somewhere in the middle. And then I show you a range of lengths for the cord there. That's by about 30 weeks. Yeah, so wider range would be somewhere in the 30 to 100. And then width is typically like 1 to 2 centimeters. So the length matters. If it's really long, then you're more likely to get a baby all entangled up in themselves, or that they manage to do some kind of acrobatic move that gets a true knot in the cord. Or if it's really long, the cord would be a little bit more likely to prolapse. So water breaks, and then instead of the head sinking down into the cervix, you have a cord coming out and then a head, which would make the cord more likely to get kinked off. So that's something to be aware of too with long cords. Honestly though, you can't really measure cords in utero with ultrasound. That sounds impossible to me, just thinking about doing ultrasounds myself. So you don't see that one coming. It's more like in hindsight you see, and then it kind of makes a little bit more sense. And then as far as short cords go, they can be associated with fetal heart tone abnormalities in labor, though usually it's more of an incidental finding. But I always have it in the back of my mind that our cord might be short because sometimes babies are born and moms reach down and they pull up their baby up close to their face and then their cord breaks. So just to be mindful that you could have a short cord and baby might not be able to make their way all that far up mom's abdomen when they're first born, and just letting them kind of settle a little bit lower until you see how much cord you've got is important so that it doesn't snap. And then the cord doesn't have any nerves or anything. Dads like to know that when they're cutting it. And then just thinking about that number of having 2 arteries in a vein, if that's not what you've got, then thinking about if you might have a GI issue or more commonly like a renal issue or a cardiac abnormality could impact the number of vessels that are in your cord. So you'll see that on your 20-week scan. Basically, all pregnant women get a scan mid-pregnancy that's an anatomy overview, and they're checking to see that there's 3 cords or 3 vessels in the cord. I like this. This is 15 minutes postpartum. You can see that all of the blood is still coursing through the cord, and then progressively it gets wider and wider and wider. So this whole time baby is still attached, and you can see how slowly over time you've got nothing left. And if you've got one section that's super white like this, even just feeling it with your fingers, there's probably not a whole lot still pulsing here. But the longer we're waiting, the more of baby's own blood he or she is getting back. So, great. And then on ultrasound here, you can see the cord. It looks like either Mickey Mouse or a scary little man like a Pac-Man. So here's a Mickey Mouse example where we have 2 arteries in a vein, AVA, 2 arteries in a vein. And then here we have our little Pac-Man creature, 2 arteries in a vein. So those are cross sections of our cord. Then here again you can see we have 2 arteries in a vein. Arteries are like smaller and more fibrous, and then that vein tends to be looser. And then when you're doing an ultrasound, which I don't know that any of you will have a whole lot of exposure in school, you may or you may not, which is partially why I'm putting it in this PowerPoint. But when you do an ultrasound, there's a button you can hit, or I don't know if it's a button on every machine, but there is a setting where you can add color, and then they can see this movement here. And gosh, I don't even really know if it's movement. That's bad. I don't know if it's motion or heat censored or what it is, but it can show you where your arteries and veins are. Which I will add this if I'm checking to do like an AFI, because if I couldn't see this very well and I thought that my largest pocket was from here to here, I can't have any cord in my largest pocket. So that's a way that you can make the vessels show up. Is that heat or motion censored? I'm just not sure now. Okay, we're on the home stretch. Thanks for hanging in. I know this was a really long lecture, and now you're going to be probably happier that I'm not necessarily lecturing every week, or that usually I'm just lecturing a little bit. So hang in with me as we do the final stretch on just looking at what some of the abnormalities would be on a placenta that you're inspecting. So circumvallate placentas, I don't put a whole lot of stock in thinking about them as abnormal, but you can see this one's folded way up. So it's just that amnion and that chorion kind of doubling back on themselves. And then you see this thick ring all the way around. It can decrease surface area for perfusion, so it could lead to intrauterine growth restriction. And then sometimes it seals fibrin and hemorrhaging even just within it. So if you do see a really thick one like this come out, this one, I've never seen one quite this prominent, you might see some hemorrhaging or fibrin within this extra pocket. But I'd say almost more often than not, I at least see a little bit of doubling right on the edge. So it might not go all the way around, but pretty common. Succenturiate lobes, and maybe I'll put bilobed in the same category. So sometimes we have this little lobe off to the side of our big lobe, and sometimes it's like we have two big lobes about the same size, or maybe moderate sized lobed about the same size, and you could just say that the placenta is bilobed. But basically this is a group of villi that have formed distant from your main placenta. It's more common if the main attachment site is a confined area, like sometimes up in the fundus there's not quite as much room for the placenta to grow in a bigger, wider area, so then you have this little subcentriate lobe off the side. I really do think of these as no big deal, assuming that they come out. But this is why when you're inspecting your placenta, you make sure that it looks like all these vessels have ended on the edge, and it's not like there's one big vessel that just kind of got broken off, because that's when you're wondering if there might still be a subcentriate lobe inside of her. But usually everything just comes out together and it's really not a big deal. Battledore placentas, so usually our placenta is inserting somewhere in the middle here, but we can see here that it's inserted right on the edge. This really doesn't have very much clinical significance. It is pretty common. Just something to be aware of is sometimes when you're providing traction, so when you're having mom bear down to deliver her placenta, and then you're kind of pulling from the other side, that's the providing traction piece, these are a little bit more likely to rip. So just to kind of be aware of that, could break it off. So gentle traction. Filamentous cord insertion is like the next step. So ideally we're attaching somewhere in the middle here, and then if not, we're inserting on the edge. That's our battledore, also known as a marginal insertion. But if it's attaching just within the chorion and the amnion, then we have all these vessels exposed that don't just go directly into our placenta, but then they also aren't covered by all the Wharton's jelly. So that really leaves them vulnerable to rupture because they don't have the protection from the Wharton's jelly. And so if you're in labor, that could mean if it ruptures, that could mean that baby bleeds out, because these vessels are baby's blood. And you don't have to bleed very much for a baby for that to have a huge impact. Their blood volume is so small. So that can be a cause for a stillbirth. Sometimes rupture of membranes could rupture it, or in labor maybe baby's head is easily compressing against it, so having issues with our heart tones, or baby's head even causing the rupture of the vessels. So not something we like to see, and again, oftentimes that's something that we don't really find out about until incidentally after the birth, kind of explaining things in retrospect. That's been my experience with it, at least. Okay, so last one here is placenta accreta, which I basically have already touched on, but that's where we're attaching at a site that could be like where the C-section scar used to be, or where a placenta had once implanted, where she'd had uterine surgery in the past, and we have our placenta growing deeper than the decidua basalis. So accretas are where they attach to the myometrium, incretas are where they get into the myometrium, and then percretas are where they go all the way through the myometrium and could start working through other organs as well. So all three of these are a mess. And the last thing I would want to have in an out-of-hospital birth. So just thinking about the risks associated with vaginal births after cesareans, I mean, the most common one we think about would be that her uterus might rupture where that scar line was once the stress of labor is put on it. But then you also have the possibility that after the baby's born, that goes fine, and then she needs to deliver her placenta, and it could be that part of it has grown into the muscle, or it could be that all of it has. So it could just be that a little section of it has too, just to be aware of that. But this is a huge potential for a hemorrhage here, to not be able to birth the placenta, especially if maybe just half of it was able to peel off, but then the other half is stuck. You have that fast rate of bleeding coming out the half that hasn't been attached. So as long as it's still attached, everything's fine. But obviously, it's not okay for it to stay there forever. And once the baby's out of here, that buckling is probably going to cause some of it to tear off. So About 75% of the time, if this is happening, it's an accreta. I mean, if you're trying to remember which one is which, it's alphabetical for you. So least invasive starts with A and then works its way to most invasive in a P. Let's see. Yeah, so basically we're not able to clamp all the way down in third stage, and that's why this is an issue. And once you do deliver this placenta, it can be really hard looking at the placenta trying to figure out what's like really maternal tissue versus what's the placenta itself. So if this is what you think you've got, you just head straight to the OR. Okay, yeah, that could be a situation where they might have to do a hysterectomy. So, okay, so placental cultural beliefs. I just wanted to spend a little bit of time and give some room for this. So, so many beliefs about the placenta, whether that's here in the States or abroad. No matter where you go, we have thoughts about the placenta. So, so really, the placenta is our link between mom and baby, and the placenta has been growing alongside the baby, so the two of them have been growing and developing and changing throughout pregnancy. You can think about the placenta as maintaining a connection to the womb as long as possible after the birth. So the baby is born, and there's so much transition happens physiologically with the baby, but baby continues to have the cord continue to give him or her oxygen. So that is the same as when baby was inside. So that that support is really beautiful. So helping to just sustain a gentle and a successful transition into life. Oh, and I think this is another one of Amy Hatterer's artwork. I like this one too. Distracting myself now. That's sweet. Oh, that's my Lotus birth chat. Okay, we're getting there. Okay, so the Navajo in the United States, as well as the Maori in New Zealand, they have traditions to bury the placenta in native soil, and they believe that that binds the child to its ancestral land and to its people. Many cultures, and I'm talking South America, Africa, Asian islands, like Indonesia and Malaysia, the Philippines, the placenta is considered like a twin. So in some of those places it's thought of as a twin, some an older sibling or a younger sibling. Many think of the placenta as having its own spirit, or thinking of it as a guardian spirit for the baby. Some cultures will bury the placenta wrapped in white linen and in a special pot, and there's a ritual around burying the placenta. Some will save either the placenta or the cord, save components of it, and then if the baby ever becomes sick, they'll feed aspects of the placenta back to the baby, like it's a medicine designed specifically for this baby, which genetically the placenta is identical to the baby. And then I read this one report, I think it was in the 60s, 1960s or maybe early 70s. This anthropologist in the Philippines and Vietnam, there were reports of midwives eating women's placentas. So that's something I hadn't considered as a possibility when I ask women what they want to do with their placenta after the birth. Give that a little more thought. Egyptians, there is so much on placentas. There's a lot of thought around duality of souls, that one of these souls is in the body, one is in the placenta. They had special tombs just for the placentas of pharaohs, and there were like intense ritual burial sessions for these placentas. They were treated with honor. This picture here is a woman, an Egyptian woman depicting motherhood. She's holding her baby here, and then she's eating figs under this tree, and you can see this tree is what looks to me to be a battledore placenta. And then over here, this is a hieroglyph. This hieroglyph means placenta, so it was meaningful enough that it got its own hieroglyph symbol. In Bali, in Indonesia, they practice lotus birth, which has kind of caught on. I mean, I don't know if I would say catch on, but there are definitely reports of it happening in the US as well. So lotus birth is when you just never cut the cord. So the baby is born, and then the placenta is born, and then usually it's going to take a few days for the placenta to just fall off on its own, maybe even up to a week. And so they'll wrap the placenta in herbs to kind of preserve it. And basically it's up to baby and placenta to decide when they're ready to be done with each other. Like not wanting to have a baby be born and then immediately sever something. To just let that happen quietly and naturally would be the thought there. I guess it was happening enough in England that the Royal College of Obstetricians and Gynecologists put out a little a purpose statement, I suppose it was probably, that basically that they were anti and based on the increased potential risk for infection with having baby continuing to be attached. And generally speaking, these aren't cultures that are taking their kids to Walmart, with a double stroller, one for the baby and one for the placenta. I mean, it's women who are staying in bed for that first week, and so it's just kind of off to the side. But both mom and baby are just kind of crashing in bed, and then you have this placenta all wrapped up in cloth that's present as well. So that's lotus birth, which I think this picture is depicting. So then you'll hear people talk about I always say this wrong. Placentophagy. That's right. Placentophagy, eating their placenta. So a lot of different animals will eat their placenta. A lot of that's thought to be related to protection, not wanting to leave their scent, as well as maybe just naturally they're restoring some of their iron, etc. Monkeys don't. Interestingly enough, I guess they would practice more of a lotus birth lifestyle. That's kind of my initial thought there. And then just for thinking about how we're treating the placenta after the birth, I would encourage you to think about the placenta as more than just messy afterbirth. I mean, all across the world, there's at least some element of a reverence for the placenta and the role that it's played in this pregnancy. So I think as much as we're able as midwives to learn how to honor the placenta, there doesn't need to be a fancy ritual around it per se. It doesn't need to be elaborate, but even just looking over the placenta and thanking it for its role in bringing that beautiful baby into the light. Perhaps it involves giving parents a tour of the placenta. I have most of my moms want to see it if they're not taking it home, but I don't know that would be true for all populations. I definitely have women that don't want to see it as well, but bringing them into just having an appreciation for the role that the placenta has played in bringing them their baby. So definitely in the U.S., I occasionally will have a mom practice placentophagy, and how I've seen them do it is they'll take their placenta home, they'll clean it really well, and then they'll chop it up into, bite-sized pieces, and then they'll throw them in the freezer, and then postpartum they'll make smoothies and throw like a cube of placenta into their strawberry smoothie. So that's what I have shown here, but in general I see that pretty rarely. Encapsulation can be fairly popular nowadays, the thought being that it's increasing breast milk supply, slowing bleeding, increasing fatigue, helping with anemia, and then postpartum mood support's probably the largest piece that I hear touted. I've yet to see any randomized controlled trials, and we can get into some of that later too to the extent that you want to, but it's definitely popular, so being aware that it's out there. And then I have a video if you want to see how it's done. That's in the bonus file this week. And then certainly art is an option. So these two corners here, these were both prints made with placentas. So putting paint on the placenta and then putting a piece of paper over it to give you a stamp. And then the last thing that I see people doing somewhat frequently would be to plant a tree. I don't know, maybe not that frequently, but burying your placenta in your yard and then planting like a rose bush with it or a tree with it, like on top of the placenta, and then that becomes like a source of um, life that's dedicated to that child, or some kind of remembrance with the child there. So there's a lot of ways that we can honor the placenta, and that's going to look a little different to every mom. But yes, so that's everything I have for this week. Way to hang in there till the very end. I really hope that's helpful, and as always, feel free to just keep rewatching certain sections. I think especially that implantation piece can be a bit tricky to feel like you've got a good handle on. And feel free to email me questions if you've got any. All right, guys, have a great week.